Good morning and welcome to our grand rounds today. It is my pleasure to introduce Dr. Kathryn Dreyer. Dr. Kathryn Dreyer began her higher education at Williams College in Massachusetts. And if I were inclined to make an esoteric joke about how she didn't get into Amherst, that's why she had to go to Williams. Only two of you would understand that if you know anything about small liberal arts colleges in New England, but at least Kathryn and I can laugh about it. She then, where she graduated, by the way, magna cum laude. She went to the University of Chicago School of Medicine. Yes, a proud alumni in the room, at least. And then came here for residency, and we were very excited to have her. Throughout her time in medical school and residency, Kathryn has been a part of 5 publications and/or poster presentations, one most recently at the SGO meeting last year. She also has volunteered her time on numerous committees within the residency and department and acted as a mentor for us as well. I will note, I think still Kathryn's most proud professional moment when I talked to her is the time she spent as a medical scribe for her own dad in his medical practice. And the fact that we have talked about that many times speaks to Kathryn's character and how much she cares deeply, not only for medicine, but for her family. Kathryn, I've noted to always be poised. She's very smart. She has incredible natural gifted operating room skills. And I'm very excited for her to continue on as a fellow in G1 Oncology at the University of Virginia, and very excited to hear her talk today.
Okay, good morning, everyone. Today I will be talking about cancer and pregnancy with a focus on the unprecedented landscape after the overturn of Roe v. Wade last year. I have no financial disclosures. During this talk, I will define the general principles of oncologic care during pregnancy. Next, I will identify the most common cancers during pregnancy, outline the treatment of those cancers, and describe how pregnancy alters that treatment. Finally, I will focus on how laws and the current political climate impact the care of pregnant patients with cancer. To make sure we are all on the same page, I want to first define pregnancy-associated cancer. This term encompasses cancer that is diagnosed during pregnancy and up to 1 year postpartum. I will primarily focus on cancer that is diagnosed during pregnancy, but want to acknowledge that the term does include those cancers diagnosed in the postpartum period, which can have implications on breastfeeding and future fertility and are beyond the scope of this presentation. Cancer is the second leading cause of death in childbearing age women. A cancer diagnosis complicates about 1 in 1,000 pregnancies. This accounts for 0.07 to 0.1% of all malignant tumors. Of those patients diagnosed with cancer in pregnancy, studies have shown that 9 to 28% choose to end the pregnancy. The incidence of pregnancy-associated cancers is expected to increase given trends in delayed childbearing. The most common pregnancy-associated cancers are breast, melanoma, cervical, lymphoma, and leukemia, which mirrors the most common malignancies in non-pregnant women at younger ages. Melanoma, hematologic malignancies, and lung cancer are the only cancers that have been reported to metastasize to the placenta and fetus. Both maternal and fetal outcomes in these instances are incredibly poor. Just like many health conditions in pregnancy, the diagnosis of cancer can be challenging given many non-specific symptoms that overlap with physiologic pregnancy symptoms. These include bloating, fatigue, breast pain and tenderness, nausea, and vomiting. This can lead to delays in diagnosis. In a case series of 26 patients looking at maternal morbidity in pregnant patients with cancer, delay in diagnosis or treatment occurred in 65% of those cases. Thus, it is important to perform a thorough history and physical at the initial prenatal appointment and perform focused exams when indicated based off symptoms throughout pregnancy. Certain lab tests can also be helpful in the diagnosis of cancer during pregnancy, and not always the ones you think. Non-invasive prenatal testing, or NIPT, as many of you know, is a screening test for fetal chromosomal aneuploidy using cell-free DNA in maternal blood. Placental or maternal mosaicism, co-twin demise, and several other factors can affect results. Cell-free DNA can be of maternal origin and can detect previously undiagnosed malignancies. Malignancies have copy number abnormalities that are widespread across the genome, which are not usually seen with a viable fetus and are starkly different than the results seen with fetal cell-free DNA. NIPT is used increasingly more in pregnancy, so the expected number of results that may be suspicious for malignancy will grow, and it is important to at least be aware of that possibility when counseling patients. In a review of NIPT consent forms, few mention that maternal disease could be identified. Additionally, a survey showed that the majority of genetic counselors know of this possibility, while only less than a third counsel on the risk routinely. When abnormal results are discovered, there have been guidelines proposed in stepwise management that include a multidisciplinary team, thorough fetal assessment with targeted ultrasound and amniocentesis or CVS, maternal microarray, and diagnostic imaging modalities. The utility of tumor markers in pregnancy is also something to consider in this population. Multiple tumor markers are elevated in pregnancy, including CA-125 and alpha-fetoprotein. Other tumor markers, such as inhibin B, can change throughout the pregnancy, with levels rising in the third trimester. And tumor markers, such as LDH, can also be a marker of hypertensive abnormalities in pregnancy. Because of these properties, these tumor markers are less reliable in pregnancy-associated cancers. Whether a patient rolls through OB triage with a productive cough and a fever or presents in the ED with severe right lower quadrant pain, the issue of imaging in pregnancy is one that comes up often and has been studied fairly extensively. This chart outlines the most common imaging modalities that we encounter and what the estimated fetal radiation dose is for each of them. It should be noted that the fetal dose is not necessarily equivalent to the actual dose of radiation in the study. In general, providers should consider avoiding complementary studies that deliver fetal doses higher than 0.1 milligray and should really be avoided with fetal doses over 10. This includes a CT of the pelvis and a PET CT. Ultrasound is generally considered safe, as is MRI. Gadolinium contrast should be avoided in pregnancy as it crosses the placenta and it can accumulate in amniotic fluid. A large retrospective study showed that gadolinium contrast in the first trimester was associated with an increased risk of rheumatologic, inflammatory, or infiltrative skin conditions. In general, caution should be used with pelvic CT, but the radiation dose from a single pelvic CT is less than 0.05 gray and has not been shown to have detrimental effects on the fetus. PET CT, while generally avoided in pregnancy, can be used in select circumstances. In these cases, protocols can be adjusted to limit fetal risk while balancing the clinical benefit to the mother, as this imaging modality has proven clinical utility in initial and recurrent staging workup. For example, during the second and third trimester, one must consider the risk of a missed stage cancer versus fetal risk of a low-dose PET CT. If this imaging modality is indicated, careful counseling must be provided. Risk of radiation depends on the total dose and gestational age, with risk decreasing later in pregnancy. This chart outlines fetal effects seen with increasing radiation doses at different gestational ages, with the most risk seen in the first trimester with the higher cumulative radiation doses. Cancer treatment usually involves some combination of surgery, radiation, chemotherapy, and targeted or hormonal therapies. Cancer treatment in pregnancy requires an interdisciplinary team comprised of an obstetrician, an MFM, a medical oncologist, and a surgeon, among others. I will provide a brief overview of these treatment categories and how they differ in pregnant patients with cancer. Overall, surgery is considered safe in pregnancy. The risk of maternal death is not increased and it is not associated with birth defects. The risk of miscarriage is slightly elevated at 1 to 2%, especially in the first trimester. There is an increased risk of low birth weight infants and premature delivery. The rate of complications and morbidity is higher in major abdominal and pelvic procedures, which makes intuitive sense. When the clinical situation allows, surgery is performed during the second trimester. There are several factors to consider in surgery for cancer in pregnancy. Pregnancy itself can induce changes in breast and cervical tissue that can mimic malignancy. Therefore, it is important to communicate to the pathologist that the patient is pregnant. Sentinel lymph node assessment is generally safe in pregnancy, as this technique causes low doses of radiation exposure to the fetus. Sentinel lymph node biopsy should not be omitted if clinically indicated. ICG dye is safe to use in pregnancy. However, blue dye is frequently associated with anaphylaxis and not routinely recommended. Finally, anesthesia is generally considered safe during pregnancy and has a risk profile similar to the general risks of surgery. Chemotherapy is generally avoided during the first trimester. The use of chemotherapy during this time increases the risk of major malformations reaching up to 20%. After 12 weeks, chemotherapy is generally considered safe. The eyes, genitalia, hemopoietic system, and the central nervous system are still vulnerable to drug exposure during this period, and although the absolute risk is low, there is a possibility for mild dysfunction during infancy and adulthood. Even though chemotherapy can be given in the second and third trimester, there are potential risks, including fetal growth restriction and possible preterm labor. If chemotherapy is given within 3 weeks of delivery, leukopenia can occur, so chemotherapy is not recommended after 35 weeks. There are several ancillary medications that are commonly used in conjunction with chemotherapy. Zofran is used for chemotherapy-induced nausea and is generally considered safe. Steroids are also used around the time of chemotherapy infusion. These are okay, but methylprednisolone and hydrocortisone are preferred to dexamethasone and betamethasone, as the latter two cross the placenta. Life-threatening infections can result from profound neutropenia during chemotherapy and require broad-spectrum antibiotics. Several antibiotics, including tetracyclines, aminoglycosides, and trimethoprim, are potentially teratogenic and relatively contraindicated in pregnancy. However, there are many antibiotics that are considered safe during pregnancy. It is also okay to give blood products during pregnancy as needed, and although data is limited, the use of granulocyte colony stimulating factor is considered safe. The typical dose used in radiotherapy is 40 to 70 grays, which is 10,000 to 100,000 times higher than the doses used for diagnostic methods. As a result, radiation is not routinely recommended during pregnancy and should be postponed if at all possible. It should be used in oncologic emergencies such as spinal cord compression, CNS Mets, or a superior vena cava syndrome, or in situations that waiting would compromise treatment efficacy. The total dose of radiation to the fetus depends on several factors, and if it is possible to keep the radiation field greater than 30 centimeters from the fetus, it is estimated that the fetal dose can be minimized. It is important to keep in mind gestational age and fundal height when considering the radiation field. It is impossible to irradiate the abdomen or pelvis without harmful effects to the fetus, and when radiation in this area cannot be delayed, pregnancy termination should be considered. Hormonal therapies are not recommended in pregnancy. Targeted therapies are generally not recommended. However, data are sparse and many decisions on whether to utilize targeted therapies are made on a case-by-case basis after extensive counseling. We will go into more detail on some of these targeted therapies later in this talk. And this is just kind of a chart that nicely summarizes the general principles of cancer treatment during pregnancy. So moving on to breast cancer. Breast cancer accounts for just over 40% of pregnancy-associated cancers. There's an increased risk of a more aggressive biological subtypes such as HER2 positive or triple negative breast cancer in younger reproductive age women. As previously described, diagnosis in pregnancy can be more difficult owing to physiologic breast changes. Most women present with a painless mass or thickening of the skin overlying the breast. Once a mass is identified, initial imaging is often a breast ultrasound that can help characterize the mass. More than 80% of pregnancy-associated breast masses are benign. In pregnancy-associated breast cancers, ultrasound is almost 100% accurate at detecting masses. Either core needle biopsy or fine needle aspiration should be performed and sent to pathology. The pathologist should be notified that the patient is pregnant because rapidly dividing cells in breast tissue that is normal in pregnancy can be confused as cancer. In the cases where a solid mass is found, mammograms should be performed, being aware that the sensitivity of mammogram is lower in young patients because of increased density of breast tissue. One study found that the sensitivity of mammogram in detecting pregnancy-associated breast cancer was 78%. As many women have advanced stage breast cancer when diagnosed in pregnancy, thorough metastatic workup should be performed. Mets to the lungs, liver, and bone are most common, which can initially be assessed via chest X-ray, ultrasound, and non-contrast MRI. The non-contrast MRI takes the place of a bone scan to evaluate for bony metastases, as the radioactive technetium can harm a developing fetus. The majority of women diagnosed with pregnancy-associated breast cancer are offered genetic testing, as a higher proportion of patients staged with breast cancer have a germline mutation. Breast cancer is treated with a combination of surgery, chemotherapy, radiation, hormonal, and targeted therapies. Surgery to treat breast cancer includes mastectomy and breast conserving procedures, as well as lymph node biopsy and full lymph node dissection. Both neoadjuvant and adjuvant chemotherapy regimens are utilized. Chest wall radiation is also a common treatment in conjunction with surgery, and the timing of radiation relative to surgery is an important prognostic factor. Hormonal and targeted therapies like tamoxifen and trastuzumab are important in breast cancers with receptor positivity. In pregnancy, 3 of the 5 treatment modalities are eliminated and the other 2 are modified. Radiation is contraindicated in pregnancy, as are hormonal and targeted therapies, and chemotherapy should not be given in the first trimester. In pregnancy, surgical planning often changes. In the non-pregnant population, lumpectomy or breast-conserving surgery followed by radiation provides similar survival rates as a full mastectomy. However, as pregnant women are not candidates for radiation therapy, the former option does not apply to them. The proximity of radiation to surgery is important for survival, and studies have shown that a delay up to 6 weeks is okay. Therefore, for women who are diagnosed late in pregnancy, breast-conserving surgery may still be an option. Perhaps one of the biggest differences in the pregnant population is that adjuvant treatments with hormonal and targeted therapies are not used. In general, targeted therapies are often equally effective with fewer toxic side effects than traditional chemotherapies, but data on their use in pregnancy either is inconclusive or shows adverse effects. Trastuzumab is an agent often used in HER2-positive breast cancer and has been shown to improve survival in these patients. Trastuzumab has been linked to oligohydramnios in the literature, with several neonatal deaths reported. This is likely due to its effects on the fetal kidney, which highly expresses HER2 receptors. Methotrexate is another agent used in breast cancer that is contraindicated in pregnancy, with multiple adverse effects on organ systems as well as fetal death. Tamoxifen is a widely used hormonal therapy in receptor positive breast cancer, but has been linked to spontaneous abortions, growth restriction, preterm labor, and genital tract anomalies similar to those seen with DES exposure. In general, prognosis for pregnancy-associated breast cancer is similar compared to age-matched controls. There have been reports and systematic reviews suggestive that prognosis may be slightly worse for pregnancy-associated breast cancer. There are several hypotheses for these findings, including less aggressive therapy due to concern for fetal effects and the difficulties of diagnosing pregnancy-associated breast cancer. When neoadjuvant chemotherapy is used, prognosis seems to be similar, but of course, this cannot be utilized in the first trimester. Although limited data exists, termination of pregnancy has not been shown to impact overall survival. This is a nice summary table of the general chemotherapy principles in pregnant patients with breast cancer, and includes a lot of the information that has been covered. It is also important to closely monitor fetal development and well-being in this patient population. This includes growth ultrasounds and antenatal testing. Placental pathology is recommended, as isolated cases of metastases to the placenta have been reported. Transitioning now to melanoma. The overall incidence of melanoma is rising. The incidence is highest at age 65, but melanoma is seen in all age groups, and about a third of female patients are diagnosed with melanoma and are of childbearing age. One study showed that 1% of female melanoma patients were pregnant at diagnosis. There is debate on how the pregnant state affects the pathophysiology of melanoma and angiogenesis, with some conflicting evidence on whether diagnosis during pregnancy has a worse prognosis than a similar stage disease in the non-pregnant population. Pregnancy has not been shown to be a risk factor for melanoma in multiple studies, including over 5,000 women. It is not uncommon for there to be a delay in diagnosis of melanoma during pregnancy. Hyperpigmentation is normal in pregnancy and can draw attention to benign lesions while distracting from malignant ones. Placental metastases are rare, and when they do occur, they don't necessarily mean fetal metastases. A comprehensive review of 27 patients with placental metastases in the early 2000s showed that 6 or 22% had fetal metastatic spread, and outcomes for both mom and baby are poor. When indicated, excisional biopsy is safe at all stages of pregnancy. Just like in any cancer, staging is an important part of the diagnosis and workup of melanoma. In pregnancy-associated melanoma, staging has implications for treatment that cannot be separated from discussing its impact on the pregnancy. If a patient is diagnosed with stage 0 disease, no further treatment is necessary. And in stage 1A, the only further workup is clinical exams. For patients with stage 1B to 2C, lymph node assessment is required to rule out more advanced disease. In non-pregnant patients, regional lymph node ultrasound with fine needle aspiration of anything suspicious should be done, ideally prior to wide local excision. If the lesion has a Breslow thickness of greater than 0.8 millimeters and there are no suspicious lymph nodes, sentinel lymph node biopsy using 99 technetium should be done at the time of wide local excision. However, in pregnancy, decisions regarding these staging procedures is more complex. Providers and patients need to think about the gestational age, the risk of lymph node involvement, and what the treatment will be if lymph nodes are positive. If more advanced disease is diagnosed during lymph node assessment, then adjuvant therapy is often recommended, as is whole body imaging. Sentinel lymph node biopsy is safe in pregnancy. However, systemic treatment is not. Therefore, the implications of sentinel lymph node biopsy and what the recommended treatment is need to be discussed with these patients prior to the staging procedure. In many cases, it is reasonable to wait for sentinel lymph node assessment until after delivery. Additionally, if initial excisional biopsy margins are clear, it is also reasonable to postpone the entire procedure, including both wide local excision and sentinel lymph node biopsy, until after delivery. This flowchart outlines the recommendations for sentinel lymph node assessment in pregnancy-associated melanoma. The most important part in this middle column is the discussion about wide local excision and sentinel lymph node biopsy and its implications during pregnancy. The first step in melanoma treatment is excisional biopsy followed by wide local excision with or without the sentinel lymph node assessment. Stage 1 and 2 disease require no additional treatment other than close follow-up. And this is interesting, as prognosis for stage 2B and 2C disease is actually poorer than for patients diagnosed with stage 3A and 3B. Based on my reading, it seems that this recommendation for adjuvant treatment in stage 2 disease will change, as this population would likely benefit from it. A positive sentinel lymph node biopsy identifies patients with stage 3 disease. And if a patient is diagnosed with stage 3 disease, they are eligible for a year of systemic adjuvant treatment with either BRAF-directed therapy or immunotherapy, depending upon the BRAF mutational status. These treatments can reduce recurrence risk by up to 50%. Both of these are not recommended in pregnancy. If a pregnant patient presents with palpable lymph nodes, whole body staging should be performed. If no distant disease, a therapeutic lymphadenectomy should be performed, which is safe in pregnancy. Stage 4 disease is impossible to treat adequately in pregnancy. It is appropriate to discuss termination or induction depending on gestational age. There are several case reports of women who were on systemic therapy and continue that therapy, which can help with the counseling of patients who decide to stay pregnant and go on treatment against medical advice. Systemic therapies are recommended for advanced stage disease. BRAF-directed therapy can be used on those melanomas with BRAF mutations and include these drugs that I won't try to pronounce right now. There is very limited data on their use in pregnant patients. Preclinical studies have shown some teratogenic potential at several times higher than standard human exposure, but not all of these agents have been tested. MEK inhibitors are classified as potentially teratogenic and should be avoided in pregnancy when possible. Ipilimumab, an anti-CTLA-4 monoclonal antibody, and nivolumab and pembrolizumab, both anti-PD-1 monoclonal antibodies, are the 3 immunotherapy drugs currently licensed for patients with metastatic melanoma. There are very limited case reports of these immunotherapy drugs in pregnancy. Healthy infants have been reported, but the use of these is not currently recommended in pregnancy. And radiotherapy is typically not recommended in pregnancy, but can be acceptable in certain instances of oligometastases, such as brain mets. Currently, the general consensus is that melanoma in pregnancy does not have a poorer prognosis compared to melanoma in the non-pregnant population, and that it is the stage of the disease that remains the most important factor to consider when counseling patients diagnosed with pregnancy-associated melanoma. However, there is some conflicting evidence about whether localized melanoma in pregnancy is associated with poorer long-term prognosis when looking at differences in Breslow thickness, overall recurrence rates, and mortality. Now we'll transition to hematologic malignancies. Hematologic malignancies, which include both lymphoma and leukemias, make up 20% of pregnancy-associated cancers. Hodgkin's lymphoma is the most common, occurring at a rate of about 1 in 5,000 pregnancies, and most of these are the nodular sclerosing subtype with stage 1 or 2 disease and an overall good prognosis. Less common is non-Hodgkin's lymphoma, and diffuse large B-cell is the most common of this subtype. Leukemias are rare, occurring in about 1 in 75,000 pregnancies, and acute myeloid leukemia accounts for about 75% of these. Lymphoma and leukemia symptoms are often nonspecific and overlap with physiologic symptoms of pregnancy. Abnormalities on initial CBC or an incidentally found nodule can increase suspicion for these in pregnancy. When a nodule is found, initial imaging includes chest X-ray or ultrasound. Diagnosis is confirmed via a core needle biopsy of a lymph node or bone marrow biopsy. Both of these are considered safe in pregnancy and should not be delayed or avoided. Staging is then completed with full body imaging. PET-CT is used outside of pregnancy, but relatively contraindicated during pregnancy. It can be substituted with a full body non-contrast MRI with diffusion weighted imaging or a CT without contrast. The mainstay of treatment for lymphoma and leukemia is chemotherapy and radiation, and in a timely fashion from diagnosis. As one expert quoted, for certain types of hematologic malignancies, quote, there really aren't alternative options for leukemia or lymphoma. You don't have the option of delaying things. It really is life-threatening in the short term, and without this treatment, the patient could die within 3 months. In general, chemotherapy is the primary treatment, with radiotherapy used in specific circumstances such as indolent stage 1 lymphoma, bulky lymphadenopathy in patients with aggressive lymphoma, and together with chemo in patients with early Hodgkin's lymphoma. It can also be used in hemato-oncologic emergencies when lymphoma causes spinal cord compression or superior vena cava syndrome. While radiotherapy is contraindicated in pregnancy, when the radiation target is distant from the fetus, like a cervical lymph node, it can be considered, and discussion with a medical physicist is important when these rare instances arise. Advanced Hodgkin's lymphoma is treated with long courses of multi-agent chemotherapy with or without radiotherapy. There are 2 typical regimens for this, and one of these 2 contains higher doses of anthracyclines and includes alkylating agents, so is not recommended in pregnancy. Overall, the prognosis of Hodgkin's lymphoma in pregnancy seems very good, and these patients have similar long-term survival compared with matched non-pregnant controls. The treatment of non-Hodgkin's lymphoma depends on the histologic subtype. Some of these subtypes require anti-metabolite therapy in the chemotherapy regimen, which should be used with caution in pregnancy. There have been reports of these being used, but there is a risk of teratogenicity. They are not recommended, especially before 20 weeks. Rituximab, which is an Ig1 monoclonal antibody, is central to the treatment of non-Hodgkin's lymphoma. It does cross the placenta, and studies have shown that movement across the placenta increases with gestational age. A retrospective study looked at 153 women whose pregnancy was exposed to rituximab therapy. A 58% live birth rate was reported, as was a 21% first trimester miscarriage rate. Additionally, a number of the infants did have transient neutropenia, thrombocytopenia, or B-cell depletion at birth. Treatment with rituximab was not associated with an increase in fetal anomalies or infection. Overall, there remains limited data for use of rituximab in pregnancy, but it is not believed to cause significant harm to the fetus, so may be considered in certain circumstances. Making the decision on whether to treat lymphoma in pregnancy is based on type of lymphoma, i.e. whether it's indolent or aggressive, gestational age, and the patient preference. Indolent disease in patients who are asymptomatic can be observed without treatment until after pregnancy, but systemic therapy is recommended in the majority of patients with more aggressive subtypes. In patients who have these aggressive subtypes and are early in their pregnancy, termination is recommended. When lymphoma is diagnosed later in pregnancy and systemic therapy is warranted, treatment is typically the same as in the non-pregnant population. Chronic myeloid leukemia occurs in about 1 in 100,000 pregnancies. The median age is typically 50, so it is rare overall in the childbearing age population. Symptoms are similar to normal pregnancy symptoms, and it is usually picked up on routine blood work. CML was the first cancer to be linked to a genetic abnormality in the Philadelphia chromosome, which leads to a fusion oncogene BCR-ABL, which is also a tyrosine kinase. Tyrosine kinase inhibitors are the mainstay of treatment in CML. Tyrosine kinase inhibitors inhibit BCR-ABL as well as other tyrosine kinases, such as platelet-derived growth factor receptor alpha. This specific tyrosine kinase is important for embryonic implantation, gonadal development, and fetal maturation. Thus, tyrosine kinase inhibitors in pregnancy should be avoided. Fetuses exposed to imatinib in pregnancy have higher incidences of skeletal, renal, respiratory, and GI abnormalities. If diagnosis is made early, it is sometimes okay to wait to initiate treatment until the white blood cell count is over 100 or platelets are over 500. This delay may be important in terms of gestational age if close to term or reasonable delivery timing. There are alternatives to tyrosine kinase inhibitors that should be considered in pregnancy, including leukapheresis and interferon alpha. Leukapheresis lowers cell counts but has to be done 2 to 3 times per week. and IFN alpha is considered safe in pregnancy after organogenesis is complete, but efficacy is much lower than tyrosine kinase inhibitors, and it has side effects, including fever, chills, and flu-like symptoms that are sometimes hard to tolerate. IFN alpha was first line for CML prior to the advent of tyrosine kinase inhibitors, but did not always provide good hematologic control. Other supplemental agents were often added, including hydroxycarbamide, which is a cytotoxic agent that inhibits RNA synthesis. If a patient with CML presents in blast crisis, prognosis is poor, and the recommendation is to manage similarly to acute leukemia, which I will discuss next. Acute myeloid leukemia occurs in every 75 to 100,000 pregnancies. Maternal and fetal health is at risk due to the profound anemia, thrombocytopenia, and neutropenia associated with both acute myeloid leukemia and acute lymphoblastic leukemia. Prompt treatment is necessary. Leukapheresis can be considered regardless of gestational age. If a patient is diagnosed in the first trimester, pregnancy termination followed by induction therapy with chemotherapy is recommended. If diagnosed outside the first trimester, induction therapy can be done without termination, although there is an increased risk of fetal growth restriction and fetal loss. Acute promyelocytic leukemia is a subset of acute myeloid leukemia that is often accompanied by DIC. All trans-retinoic acid is critical to treatment and induces differentiation of leukemic cells. However, it is highly teratogenic during the first trimester, so termination is recommended prior to initiation of the drug. It can be used after the first trimester. Arsenic is teratogenic throughout pregnancy and should not be used. Acute lymphocytic leukemia has some similarities to acute myeloid leukemia, but several other factors need to be addressed. CNS prophylactic therapy is required and is comprised of methotrexate and L-asparaginase, which are toxic to the fetus. Methotrexate should not be given prior to 20 weeks. Some ALL patients are Philadelphia chromosome positive, warranting tyrosine kinase inhibitor therapy, which as stated previously is not recommended in pregnancy. Therefore, in patients who are diagnosed with ALL prior to 20 weeks, termination should be discussed. If diagnosed after 20 weeks, chemotherapy can be used until postpartum when tyrosine kinase inhibitors can be used. This chart is a summary of the typical treatment of hematologic malignancies and how those are adjusted in pregnancy, which I have gone over a lot of this. And this is a summary of the agents used in lymphoma and leukemia and their associated teratogenicity at different gestational ages. In general, organogenesis is affected in the first trimester, and fetal growth restriction or low birth weight is the most common adverse effect seen in the second and third trimester. And the last one I'll go into kind of more detail on is cervical cancer. Cervical cancer is rare in pregnancy and occurs in 1.4 to 4.6 out of every 100,000 pregnancies. Because the peak incidence of both childbearing and CIN is during the third decade, PAP is recommended if due at the initial prenatal visit. If indicated, colposcopy should be performed while omitting endocervical curettage. Cervical biopsy during colposcopy has not been shown to increase miscarriages, so should be done where indicated. One should use caution with biopsy, as we all know the cervix in pregnancy is very well vascularized, and so you want to prevent unnecessary bleeding. If HSIL is identified, excisional procedure is recommended to rule out invasive cancer. MRI is the primary imaging modality used in the staging of cervical cancer and assessing tumor extent. In the non-pregnant patients, tumors are T2 hyperintense on MRI. In pregnancy, the cervix is T2 hyperintense at baseline, which makes it slightly more difficult to evaluate this in pregnancy. Guidelines for the European Society of Urogenital Radiology state that diffusion-weighted imaging helps distinguish tumor from cervical tissue in these instances. PET-CT is often used in conjunction with MRI in cervical cancer. While it is typically avoided in pregnancy, changes in protocols can be made to limit fetal exposure, and case reports have shown good outcomes. PET-CT can be useful in staging, treatment planning, and assessing therapy response. In patients where sentinel lymph node sampling is necessary, laparoscopic assessment using ICG dye is okay in pregnancy. Advancing gestational ages beyond the mid-second trimester, however, can make this technically impossible. This is just a little refresher on cervical cancer staging, which was last updated in 2018. And the asterisks represent where the 2018 staging differs from the 2009 staging. Stage 1B tumors are now subdivided into 3 categories based on tumor size, and suspected lymph node involvement on imaging is now included in stage 3 disease. Surgery is a treatment modality often employed for early stage cervical cancer. Cold knife cone and simple hysterectomy can be completed for stage 1A disease. Patients with stage 1A2 to 1B2 and some 2A1 disease can be treated with radical hysterectomy and radical trachelectomy if fertility sparing is desired. For patients with more advanced diseases, chemoradiation is the mainstay of treatment. Patients are typically treated with weekly cisplatin with external beam radiation therapy, followed by vaginal brachytherapy. In patients with stage 4B disease, palliative radiation and chemotherapy are employed. And I have to give credit to Dr. Kushner and his CREAG review for this slide. Radiation therapy for cervical cancer is contraindicated in pregnancy. When necessary, termination should be offered. Surgery can be completed, but needs to be modified based on the stage, gestational age, and patient wishes. There are several proposed management schemes. In patients with undesired pregnancy or those who wish to proceed with standard treatment, termination can be offered, followed by fertility sparing or routine surgery. In patients who want to continue their pregnancy and are before a viable gestational age, surgery has to be modified. For patients with stage 1A1, cold knife cone can be performed, keeping in mind not to make the incision too deep. Cerclage can be considered to prevent premature delivery and surgical bleeding. For patients with stage 1A2 to 1B1 with no lymph node involvement and tumor size less than 2 centimeters, studies have shown that less than 1% have perimetrial extension. Therefore, cold knife cone can be considered in these cases. Also mentioned in the literature is a simple cervical resection in these patients, which up until preparing for this, I had never really heard of. Radical cervical resection is not recommended in pregnancy. If the fetus is viable, delivery timing should be discussed. When possible, pregnancies are delivered at early term with scheduled cesarean section. Vaginal deliveries can cause massive hemorrhage and vaginal lacerations. In the setting of locally advanced tumors, low transverse incision should be avoided in order to avoid cutting into the tumor. When indicated, lymph nodes should be assessed in pregnancy, and if lymph nodes are positive and fetus is pre-viable, termination should be discussed as treatment involves chemoradiation. However, if the patient has strong desire to continue the pregnancy, it is reasonable to give neoadjuvant chemotherapy with plans for radiation postpartum. In general, in cases where definitive management of cervical cancer needs to be postponed until postpartum, neoadjuvant treatment with cisplatin and paclitaxel is considered. Risk to the fetus is low overall, although it has been associated with low birth rate and rare anomalies. While we reviewed some of the most common pregnancy-associated cancers, there have been many others that have been reported in pregnancy. Recently, there have been several ovarian masses removed during pregnancy in our department, so I thought I would just comment a little bit on those. In this context, ovarian masses are usually identified on routine obstetrical ultrasound. Most are benign, but some are not. Some of the most common neoplasms seen are germ cell tumors, with just germinoma being the most common, and borderline tumors. MRIs can be helpful in these cases and can risk stratify these masses with scoring systems such as ORADs. When removal is indicated, surgery should be scheduled during the second trimester. Thyroid malignancies comprise 3% of pregnancy-associated cancers. Ultrasound is very sensitive for detection, and biopsy is necessary to confirm thyroid cancer. And is safe in pregnancy. Patients should be closely monitored, and surgery can usually be delayed until after delivery. Radioactive iodine is contraindicated in pregnancy, and prognosis in these patients is similar to matched non-pregnant controls. Oops. And then just to touch on colorectal cancer, the rectum is the most common site of colorectal cancer in pregnancy. Colonic perforation risk is higher in pregnancy, so caution should be taken with colonoscopy. It is often advanced stage a diagnosis. If it is diagnosed prior to 20 weeks, surgery can be performed. If diagnosed after 20 weeks, surgery is often delayed until fetal viability. And earlier surgery should be considered if the life expectancy of the mother is low. Chemotherapy can be used in the second and third trimester. Last June, the overturn of Roe v. Wade decision changed the landscape of abortion nationwide, which in effect changed the landscape of pregnancy-associated cancers. This landscape is vast and largely unexplored in the United States. So where we are, it is estimated that 26 states will outlaw or severely limit abortion. A JAMA Oncology viewpoint analyzed the predicted effect of these new restrictions on the care of patients with pregnancy-associated cancers. In 2020, there were 3.6 million births in the US and 1.5 million were in the states predicted to outlaw or severely limit abortion. It was estimated that at least 1,500 women would be diagnosed with pregnancy-associated cancers. Based on the occurrence rate and the estimated termination rates, the authors predicted that somewhere between 135 and 420 of these women would experience cancer care that was compromised or potential loss of life. Additionally, many of these states have strict laws and penalties for abortion providers. In Texas, this can mean life in prison and fines exceeding $100,000 unless the physician performed the abortion in an emergency to save the mother's life. This is a general timeline surrounding abortion laws in Wisconsin, although it is not comprehensive. In 1849, abortion was criminalized unless the pregnancy endangered the life of the mother. Multiple laws since then, specifically after Roe v. Wade in 1973, acknowledged the right to an abortion up until viability while enacting many trap laws to try and restrict it. However, with the Dobbs decision less than a year ago, Wisconsin has reverted back to the 1849 law. And I know this is review for most people in the room. This statute states that abortion performed by anyone other than the mother is a felony, except in an emergency in order to save the life of the mother. Note that unborn child in this statute applies from conception until it is born alive. There are serious implications of the overturning of Roe v. Wade in pregnancy-associated cancers. As I hope you have learned so far in this presentation, recommendations about continuation versus termination of pregnancy is clear in some instances and not so clear in others. Most agree that termination is recommended in early gestations when patients are diagnosed with acute leukemia, and most agree that pregnancy can be safely continued in situations like early stage melanoma, where no additional treatment is recommended. However, for many other cases, the risks and benefits of all possibilities should be discussed, and the best decision will vary on a case-by-case basis. Cancer treatment and pregnancy management is incredibly individualized and nuanced. It has vast implications for both physical health and psychosocial health. These laws create confusion and fear, which is what they are designed to do. These laws put the impetus for proving an imminent life-threatening situation on the provider, and put providers in a role where they have to think like a lawyer and not just a physician. One of the hardest things about where we are is that there is no precedent. I highly recommend listening to this podcast, Crossing the Line, episode 9, in which both Drs. Berlet and Dr. Leconte, who's one of the medical oncologists here, are interviewed and discuss the implications of strict abortion laws on the care of cancer patients. Dr. Leconte comments on the 1849 law and how it relates or doesn't relate to pregnant cancer patients in present day. She states that in 1849, women couldn't vote, we didn't give chemotherapy, and radiation wasn't a thing. Health disparities are already present when it comes to abortion care and will only increase as these laws expand. Women with pregnancy-associated cancers will add to these disparities. Women who can cross state lines will still have abortion access and thus access to more treatment options, while those without the resources to travel will have different, more limited options to treat their cancer, which is awful. I want to share some direct quotes from medical and legal experts since I think they capture the current climate in pregnancy-associated cancer in a really clear and thoughtful way. This first quote is from Katie Keith, who is a lawyer and also has her MPH and is the Director of Health Policy and Law Initiative, the O'Neill Institute for National and Global Health Law at Georgetown. Many of these laws are written vaguely, and some of them are very, very old and completely unclear. I think ambiguity is the point and is meant to have a chilling effect on providers. An additional wrinkle for oncologists and patients with cancer is where does the need for cancer treatment fall in compliance with these bans? Even though there are some exceptions for the life of the mother, they do not clearly explain how sick the mother must be to justify an abortion. I think we are going to start seeing a different application of these laws, and I'm waiting for the cases of harm to the fetus due to treatment brought to court. If these cases focus on providers, we are going to be in a whole new world. This next quote is from Dr. Julie Grallo, who is the Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology. The whole question of who defines that the mother's life is in danger is one we must answer. Is it the oncologist, the gynecologist performing the procedure, the hospital, or the lawyers? It's just not clear. When it's cancer and you're seeking an abortion so that you can get started on treatment, who defines that as an emergency? Fear of lawsuits is also going to delay things that aren't imminently life-threatening. This third quote is from Dr. Alice Mims, who is section head of acute leukemia and myeloid malignancies at Ohio State. I focus on treating acute leukemias. Sometimes patients need to start treatment within a matter of hours or days and cannot wait weeks or months until they are past pregnancy complications from their disease. The other concern is, what if you prescribe chemotherapy for someone in her second or third trimester when hopefully it would be safer for the fetus, but there is still a poor outcome with the pregnancy? What if the patient has a miscarriage or there are fetal abnormalities because you treated through the pregnancy? There is also concern that we could face litigation in the future if the patient is not allowed to undergo a medically necessary termination. These decisions must be made very quickly. The question is, how do you still take good care of your patients when you have this sword hanging over your head? While there is no real precedent in the United States, we can look to other countries and news reports to start to understand how these laws can tangibly impact pregnant patients with cancer. Poland passed a near complete abortion ban in 2021, and since then, there have been reports of women being denied cancer treatment because it could harm the fetus. Similar reports have come out of other countries with strict abortion bans, such as the Dominican Republic and Nicaragua. In September 2022, a New York Times report discussed how some oncologists in Texas were saying that they would wait for a pregnant woman with cancer to get sicker before treating her, because the standard of care would be to abort the fetus in a life-threatening situation rather than give treatments that damage it. In Ohio, there have been affidavits showing that pregnant patients with cancer had to travel out of state to get abortions when doctors refused to treat them while pregnant. And here in Wisconsin, I wanted to transition a little bit and highlight a few cases of pregnancy-associated cancers provided by faculty and residents that highlight some of the challenges and nuances of treating these patients. The first case is a case of acute myeloid leukemia. This was a 37-year-old G2B1 who presented for a new OB visit. She had COVID 3 weeks prior and had a persistent cough. Her cardiopulmonary exam was normal, and her new OB labs were significant for a white blood cell count of 70, predominantly lymphocytes. Her labs were repeated and confirmed the results. She was referred to hematology, where she underwent bone marrow biopsy and was diagnosed with acute myeloid leukemia, and she was treated with chemotherapy. No one discussed the option of termination with her. The second case is a case of melanoma. A 35-year-old G3P2 at 6 and 5 presented to her new OB visit in February of 2022 after a recent diagnosis of melanoma on excisional biopsy of her paraspinal region. She had an MFM consult shortly thereafter where she was counseled on all possibilities. At that time, the patient was considering termination should her staging workup indicate the need for systemic therapy. She underwent wide local excision with bilateral sentinel lymph node biopsy with negative margins and negative sentinel lymph nodes. She delivered a healthy infant at term and her placental pathology was normal. She will continue surveillance with dermatology for 5 years. And this third case is one breast cancer. A 31-year-old G2P1 was diagnosed with triple negative breast cancer in the setting of a first trimester pregnancy in 2020. This was a desired pregnancy, and she was counseled on all of her options. She ultimately decided to proceed with termination so she can, quote, focus on her treatment and achieving the best outcome. She underwent neoadjuvant chemotherapy with ACT. She then had a partial mastectomy with sentinel lymph node biopsy followed by radiation. She subsequently carried a healthy pregnancy to term and delivered via repeat C-section with bilateral self-pingectomy. So where do we go from here? Number one, continue to vote. The outcome of the election for the Wisconsin Supreme Court this month was promising, and we are hopeful that the landscape for abortion care in Wisconsin will change later this year. In the meantime, when confronted with a pregnant patient with cancer, it is important to have a thorough discussion with the patient on all her options and her personal goals and wishes. It is vital to involve a multidisciplinary team as these cases are challenging on many levels, and experts in multiple areas are often needed to optimize outcomes. Given the current abortion laws, if there is a question of threat to the health of the mother, you may need to involve hospital lawyers in the discussion. This is an added layer to an already incredibly charged situation and one that will hopefully not be necessary forever. And if termination is desired or indicated, the care team should help provide resources and information for obtaining these services where it is legal. Unfortunately, more clear guidelines could come from cases and lawsuits over time, which could take many years. So now to just kind of sum things up, pregnancy-associated cancers are rare, which limits the amount of safety data regarding treatment available in the literature, especially for newer biologic treatments. Management of pregnancy-associated cancers requires careful consideration of both maternal and fetal health and well-being. Pregnancy termination is recommended in certain circumstances and should be an option in all circumstances. Current laws that restrict abortion services add an unnecessary obstacle in an already challenging clinical situation and have the potential to negatively impact the cancer care in this population. I would like to thank everyone for their attention. And I want to give a special thanks to Drs. Berlet and Bizzuto for their insight into this topic as I prepared for today. And I'm happy to take any questions.
Thank you, Kathryn. We're going to give 5 minutes to get to where we need to go. So we have time for one question or two, either from the audience in the room or on Zoom.
I think that's a great question. And I think Jackie Adams gave like a talk kind of about how other like maternal things can be caught on NIPT. So I don't know that I necessarily would say like we could find cancer, but certainly including like sometimes we do find maternal diagnoses from this. It's rare, but I just want, you should be aware that we might find something. Yeah.
Another question from the audience or over Zoom? Thank you, Kathryn. Thanks for everyone coming today.